Everyone. My name is Joseph Roberts. I go by Joey. I'm the newest addition to the GI clinic. Although as I say that, I realize I've been here for about a year now. I'm not exactly sure how that happened so quickly. And I'm very happy to be here. I was very honored to be asked to give a talk. And just listening to the last talk, I think this is a nice collection of talks that we've got going on, talking about colon cancer, and then cancer prevention of the gynecologic system. And then I'm going to talk a little bit about the pancreas and bile duct. And my idea for this talk was really in reflection of the sorts of questions and referrals I've been getting. A lot of the messages I might get through Bolt just when I happen to be on call, or staff messages. And it really happens to do with a lot of the incidental findings that I think that a lot of providers are finding either in the emergency room or primary care clinic or specialties when they're looking for other things. Pancreatic cysts being the one that seems to provoke most consternation, as well as an asymptomatic patient with dilated bile duct. So my hope was to give an overview of these two things. I gave a talk, a grand rounds talk on pancreatic cysts when I was in fellowship. You know, it spanned an hour and we went over because there were so many questions. It's a very, unfortunately, sort of complex and not well studied, or at least there's not a lot of literature that everyone agrees on about it. So I'm going to go over kind of the basics and my general approach and explain where the limitations are. And hopefully that provides a framework for people going forward. And then similarly with the dilated bile duct, to talk about, you know, when we see something like that, what are we generally thinking about? What are the concerns that we have? And are there specific recommendations or next steps that we would usually follow? So without further ado, next slide. So pancreatic cysts. I know this picture kind of seems a little gross because those cysts are artistically rendered in such a way that they're quite prominent. But, you know, the pancreatic cysts are really exploding in terms of incidence, and really that has to do with the frequency of abdominal imaging that's getting done. As I'm sure everyone's aware, the number of CT scans, MRIs, ultrasounds, just general abdominal imaging for multiple different symptoms unrelated to the GI tract and related to the GI tract getting done has led to really a dramatic increase in the number of pancreatic cysts. And, you know, as you can see, 13% of all abdominal imaging is quite a high percentage. Interestingly, though, we are not seeing a concurrent rise in pancreatic cancer. And so, you know, that obviously tells us that most likely this is, we're just picking up more of these that have always existed in the population. And as far as we can tell, there's no clear signal that there's a true rise in the number of cysts, given the fact that there does not seem to be a rise in pancreatic cancer. Despite that disconnect, there is a risk of cancer associated with certain pancreatic cysts. And generally speaking, the rates are somewhere around 1%. It certainly varies, and it definitely varies on what kind of cyst, which we're going to get into, and its characteristics. But it's not something that we can just shrug off, unfortunately. It is something that requires some degree of thought and likely some degree of extra testing or surveillance. Next slide. And of course, the biggest thing that we're worried about is the potential for malignancy. The transformation rate, quite low. It's probably somewhere on the order of Barrett's esophagus turning into esophageal cancer at less than 1%. It's likely lower than that. The problem that we're running into is studies that have been done to track this are a bit lacking, and the ones that are done, their follow-up windows are actually not quite long enough that you'd expect to really catch a lot of cancers that would take many years to develop. Most studies run for a few years. At best, you get 5 years with frequent imaging looking for sort of transformation, and that rate of transformation is low. On the other side, there are autopsy studies and surgical literature, especially surgical literature that looks at cysts that are removed, where then the pathologist gets the entire cyst to look at and sections it. And when they find dysplasia or precancer, you know, they'll call that as a cancerous lesion. So then it seems like, well, these cysts really are a big source of malignancy. And so we really have to figure out, you know, what is going on between those two differences. And I think there's some thinking now that a lot of pancreatic cysts may start to harbor some malignancy, much like the prostate gland may harbor some malignancy, but never actually gone to be clinical cancer, somewhat similarly. But again, these are areas that researchers are really looking at, and something they're trying to discern. And that's why we have these guidelines that I'm going to get into in terms of how we watch these things. That being said, some cysts are completely benign. And this table here is really just to make it clear that this pancreatic cyst literature is very confusing and complex. I think there's a pathologist out there that's just having a great time just coming up with all these names for all these different kinds of cysts with different characteristics. And I think it's a reflection of the fact that the pancreas is a complex organ, both being an exocrine and endocrine organ, multiple hormones, multiple different cell types. And so any of those start malfunctioning, you can really develop cystic structures. And so the biggest issue, and I put this slide up really just to make it clear that, I would say about half the time I can be very certain I know exactly what kind of cyst it is once we've kind of evaluated it. But other times there's going to be a degree of uncertainty. There's going to be the inability to know unless we were to truly excise the whole thing. And the key for me, or at least how I see my role, is to really educate patients on what reasonably I think their risk can be, and to also try to figure out which patients fall on the neoplastic side and which patients fall on the non-neoplastic side. Because certainly the non-neoplastic side, we don't need to follow those anymore, and really reduces our healthcare spending. Whereas the neoplastic side, we're talking about surveying people for potentially the rest of their life. Further evaluations, and certainly the reason that I see most of these pancreatic cysts is I'm the provider in our group who does endoscopic ultrasound. And that's part of the further evaluation that we often do. And I'll get into a little bit more what we do with that procedure and how it's been studied later on. But this is what most people come to be seen for, at least when my partners send them to me, or they get to me, is, do we need to look at this? Can we get more information with this endoscopic ultrasound that would change how we're going to manage this, or at least how we're going to talk about surveying it over time? Or in rare cases, are we just going to go straight to surgery? And the reason we hem and haw about surveillance and monitoring is because, unfortunately, these cysts are not like colon polyps where we can just do a colonoscopy and remove them and we're done. And somebody goes about their life and they never have anything happen. For pancreatic cysts, you're either talking about a Whipple, which is a major surgery, and I can count on like one hand the number of patients that have had a Whipple that feel asymptomatic afterwards. Or you're talking about a distal pancreatectomy, which generally is much more benign, but often involves taking spleen out as well. And there's a whole host of morbidity associated with these surgeries. So because surgery is so morbid for this organ, we really don't go quickly to resection unless we're pretty convinced something needs to be removed. Next slide. So here, very busy slide that we'll go into a little bit. I really like this table that I found in one of my articles, and then I put in these pictures of some sort of representative cysts that I've seen. These 4 cysts are by far the most common. For the vast majority of cysts that I'm seeing under endoscopic ultrasound, or based on the results that I get if I do a needle biopsy, are these 4 cysts. And you can really see, as you look at this table, that it's unfortunate that the gold standard really would be to resect it. And it's just not practical, as I said previously. So we rely on a lot of softer factors. We rely on, is it a man or a woman? Mucinous cystic neoplasm, that's the MCN, very, very common, or almost majority are in women. You very rarely see that in men. So already, if it's a woman with a cyst, I'm leaning that direction. The part of the pancreas that it's in percentage terms, some cysts are much more likely to be in the body and tail of the pancreas, whereas others can be anywhere throughout the pancreas. So that's a consideration. Age of the patient, depending on your age, it puts you at risk for different cysts. And then, of course, the appearance, certainly, is it multicystic, is it unilocular? And then the clinical history is also quite informative. And so the mucinous cystic neoplasm is one of our neoplastic neoplasms that has a high risk of becoming pancreatic cancer if left alone. You see that one on the left. It tends to be, I've seen it most of the time as one big cyst with a few septations. Other times it looks a little bit like that cluster of grapes. And classically, the 2 that I've seen have been, since starting here at Valley, have been out of the tail of the pancreas in 40-ish-year-old women. The second picture, the main duct, IPMN. IPMN is the one that I think I describe most commonly, and what it is really just a mucinous cyst that's either off a branch duct of the ductal system of the pancreas, or it is part of the main duct. And we really make that distinction because the main duct has a much higher risk of cancer conversion than a branch duct. So a lot of the times, if you're ever reading my endoscopic ultrasound reports, I'll often say it seems consistent with a branch duct IPMN. And usually those are the ones that we like to monitor. Serous cystic neoplasm and pseudocysts, those are non-cancerous cysts. And it's always very exciting when we get these findings, because I can tell people, you know, we're good, we're done, we don't need to really follow that unless we're supposed to develop symptoms. You know, the serous cystic neoplasm, you can see that picture, it's just much more echogenic. It tends to be a bit more solid components to it. It's a bunch of tiny little cysts. And its CEA level is low. So the first two cysts, the CEA level, basically it's a marker for mucin. And if you really get into the literature, the cutoff for what is abnormal is very hard to find, but usually I use 200. So if it's less than 200, I'm not concerned, or at least not overly concerned. If it's above 200, then I say, okay, it's definitely rising and we need to be watching that. Those are because it has a higher lytic potential. The serous cystic neoplasm CEA is low, so I don't worry about it. And then pseudocysts, it also should be low. The pseudocysts, you know, I include, it is a cyst we see in the pancreas. Usually the radiologists are pretty good at picking those out because they're given the clinical history of an episode of pancreatitis or findings of chronic pancreatitis, which is generally how you get pseudocysts. But they have a pretty characteristic appearance under endoscopic ultrasound. This sort of just, they look like they're full of a thicker fluid than general cysts. And when I do sample them, their amylase is very, very high because they're in connection with either the pancreatic parenchyma or the Duct system, because they're an abnormal inflammatory collection. And if that fluid analysis is conclusive, or the imaging is already conclusive, sometimes these are the cysts that I will drain transgastrically by making a connection between stomach and the cyst when they become large enough to cause early satiety or other complications from mass effect, to drain that cyst into the stomach instead of perk drains, which is just a newer thing in the last few years that we're doing. Next slide. High-risk features, you know, these are the high-risk features I quote to all my patients when I see them in clinic, and generally radiologists are quite aware of it as well. And so I'm sure many of you have seen them reference some of these things in their impressions, where, you know, they'll say the main duct is dilated, or they'll say there's a connection to the main duct. And again, that's the distinction for main duct IPMN or branch duct IPMN. A lot of times they'll say, you know, can't discern if it's touching the main duct or not, and that's a common reason that people will come to me as well. But so basically, you know, any abnormal LFTs is already something that's pretty high risk. Main duct being dilated to 10 or 5 is concerning. If there's mural nodules, so like a little lump or something within the cyst, that's concerning. That's early malignant transformation of the cyst wall. Cyst size over 3 centimeters, generally speaking, that's something that I need to take a look at. And then, is it growing? And that's a lot of where that surveillance comes in, because if something's not growing, just like a pulmonary nodule over a period of years, you know, they can be assumed to be benign, or at least spaced out on their surveillance in the right context. I include these 4 different guidelines just because to make, again, clear the constant sort of arguments in the GI field as to what to do with these cysts. It is an area that is always debated at all of our national meetings with some very strong opinions from the experts in the field about what's best. And the last time the guidelines were revised by one of my mentors at the university, he gave the talk and said he got a bunch of emails with some very angry endoscenographers that monitor these cysts, because generally we're in, overall we're moving towards less interventions rather than we were doing in the past. And that can make some people unhappy, unfortunately, but certainly I think the data would seem to bear out with that. Next slide. Secondary risk factors to be aware of. These ones are the ones that are pretty obvious, and I think not really fitting with the true asymptomatic pancreatic cysts that I designed this talk around. But if they mention that the upstream pancreas seems atrophic in their report, that's quite concerning. And that implies a degree of chronicity and obstruction. And anecdotally, nearly every pancreatic mass that I've diagnosed here at Valley in the last year, and there's been about 12 to 15 of them, the upstream duct is just very withered away. And that's that atrophic appearance that you can see in this picture. Elevated CA19-9, obviously high risk. The patulous ampulla fish mouth sign, we wouldn't really see that unless I was doing the endoscopy, but what that reflects is a main duct IPMN where the duct of the pancreas right at the ampulla is dilated. And you see thick feature. New onset diabetes and acute pancreatitis are things that I definitely want to bring up, but certainly my goal is not to convince you that everyone you're diagnosing with diabetes must have a pancreas cyst or pancreatic cancer. That's clearly not the case. But in somebody who's getting diabetes, that seems just abnormal. You know, for example, they're extremely fit, don't seem to have a family history of diabetes. Now they're getting diabetes. You know, that should at least prompt some consideration for workup. And then, of course, acute pancreatitis with no clear cause. Certainly, stone disease being the most common cause of acute pancreatitis in the United States, followed by alcohol, and then a host of less common things like hypertriglyceridemia, autoimmune disease, medications, that kind of thing. If those are all negative or just don't seem likely, and we have no explanation for their pancreatitis, usually those are the people that I will consider doing a further workup, because you're worried you're missing an early lesion that is actually causing this, or even a cyst. These guidelines here, so this is just a couple articles in case anyone wanted to go read the literature. These are just two papers that I'd recommend if you really want to get into the weeds about these pancreatic cysts. You can tell from the title of the first one that, you know, some people are really making their name just comparing guidelines from the different societies to try to figure out whose guidelines are the best. And, you know, we're constantly sort of limited by our lack of solid surgical data, because we just don't operate on all of these. So it's a lot of extrapolation, and the ones that end up going to surgery give us a lot of our data, but how much of those people would clinically go on to cancer is really hard to say. We just don't have that longitudinal data, but it is an area that's actively being discussed. The best way to follow these, the best way to sample and manage them is constantly being talked about. And then our colleagues up at Virginia Mason put out this paper about guidelines for endoscopic ultrasound for the evaluation of stratification of pancreatic cysts. Really just doing a nice evidence-based study, really just looking at all their EUSs over, I think it was 2014, maybe 2014, 2015. And they're a big tertiary care center. I believe there's 5 physicians up there that do what I do, and they all seem quite busy. So they're a big catchment area. They're publishing their data just saying that EUS was quite helpful for downstaging cysts. Actually, I think that might be my next slide. All right, well, it's going to be a future one. Obviously, I would have rejiggered these if after I practiced this morning, but we'll come back to that. In terms of what we do, what I do with the EUS fluid, you know, the ultrasound lets me see a lot finer detail than imaging is generally going to allow for. And it's also in real time. What I tell a lot of my patients is that a CT scan and MRI, you know, particularly MRI when somebody doesn't move, are extremely good studies. And if they're not showing a mass, I'm generally not worried at all. But there are limitations that they are a moment in time. You know, if you took a picture of somebody running and showed it to some aliens and said, this is what a human looks like running, it's very different than a video of somebody running. And that's really the difference between a static image and doing an endoscopic ultrasound, because the patient is breathing, I'm moving the scope, we're sort of panning across the cyst multiple times, and really just trying to see all aspects of it. I was struggling to get a video uploaded, so unfortunately I can't show one, although perhaps in a future talk I'll get that chance. But what we're able to see under endoscopic ultrasound when you're able to get good windows, which we generally can, is, in my opinion, a bit superior to the static imaging. And additionally, it allows for sampling of the fluid. So generally speaking, what I'm using is a 22 gauge needle, a very thin needle that is sticking into the cyst and aspirating out some fluid. And send that for the CEA level and the amylase level to try to make a distinction of what kind of cyst it is. And then just recently, here at Valley, I brought in the ability, we contracted with another specialty pathology company that can run the fluid for mutational analysis. So looking for mutations in KRAS and GNAS, that when you see those, have some pretty good evidence that those are signs of kind of early transformation into a new phenotype. And so now with generated pancreatic cysts that I'm concerned about, we'll be doing that testing as well. Again, just getting more information. That's the name of the game. Next slide. These are just a couple of pictures of EUS, and really the top picture is evidence of a mural nodule. So that's kind of what we're talking about, is this just very subtle, hazy gray blob inside of the cyst. And those can be very difficult to see on an MRI or a CT scan in particular. CT scan, MRI, sometimes you can see them, but EUS really lets you see things. You know, that thing is probably about 2 millimeters in size, and it's something that can be sampled directly with a fine needle biopsy instead of an aspiration, where you really just try to get a piece of that to allow for our pathologists to see if they can help us out a little bit more. Additionally, the below image is another tool we've been thinking about it, but basically what that is, it's hard to make it clear, but that's a needle into the cyst, and then coming out of that needle is a little forceps. So a tiny little forceps is going through the needle and can open up in the cyst and grab a piece of the cyst wall. And that really helps our pathology department do more with the information I give them. So they're actually getting tissue to look at instead of just spinning down for cytology. These cysts, generally speaking, are very acellular. So I send cytology on every one of them, but 99% of the time it's an acellular specimen and they can't tell me much. This was the slide I was thinking was coming up next for that Virginia Mason study that they showed that for patients with one high-risk feature, EUS is able to downgrade them or prove that they're completely benign and so don't necessitate any follow-up. So for me, I think that that's a really strong value to the procedure. If I can at least put someone's mind at ease, put someone's doctor at ease, hey, this is benign, we don't need to worry about it. Or, hey, yes, it is a mucinous cyst and it's something we should keep an eye on, but at least we know. Next slide. The main takeaways that really I was just trying to come across with this talk is that, cysts are incredibly common. They're becoming more common as we're imaging everybody. They, generally speaking, are not going to become cancer. The risk is low, but there are high-risk features that we look for. And generally, on the first-time diagnosis, we certainly would recommend at least a second image or some sort of surveillance if there's concern over a period of time. With EUS, I can generally get more information and get a sample of the fluid, which can give us more information still to decide, is this something that needs to go straight to surgery, or is this something that we can watch with imaging, or is this something that we're done? We don't have to do anything else about. The guidelines do keep changing, and so I do expect that to some extent there'll be some fine-tuning a little bit over the years, just in terms of our sequence. But if you go to the next slide, I did include the flow sheet that, generally speaking, this is what I follow. Really, you find your cyst. Is there anything on that initial imaging that just says it needs to be removed, or see the cancer team? It's a pancreatic head mass. That's obviously very different than a cyst. If they're saying anything solid, anything like the word solid, that's different than a cyst, which is really fluid filled. Is there a mural nodule? Is the duct huge? I will say, this flow sheet basically says any of those things are there, they should maybe go to surgery. I would say that I've yet to find a surgeon who's really been willing to just go remove a piece of the pancreas without at least an attempt at a biopsy so that they know what they're dealing with. Plan their surgery appropriately, again, because it is just such a morbid surgery. And then also, one other thing this sheet doesn't really talk about is that certain patients are not surgical candidates. You find a cyst, an asymptomatic cyst, doesn't seem overly concerning in an 80-year-old. I think you could make an argument that we don't need to survey that. If that person says, oh, I would never want a Whipple, I would never want that to be done, then all of the surveillance is really moot, because why would you be looking? I think certainly some patients will say, well, I might want it if it becomes cancer. And that's, of course, a reasonable thing to say. And so then I do offer surveillance. But I think having that conversation, which again is a conversation that I have with them, is, would you want the surgery? This is kind of what it involves. And that can inform who then will follow. But then as you just move down this, it really comes down to a size thing more than anything. Smaller cysts, the radiologist will recommend following. And actually, I'm sure that many of you have seen this in their impressions, where they see a pancreatic cyst and they'll paste in this little paragraph. For cysts 1 to 2 centimeters, we recommend CT MRI every 1 to 2 years with some sort of interval. And as they get high-risk features, or if they get larger, then they start recommending EUS even in their impression. And so that's generally what I follow as well. Certainly, I'm more than happy to talk with any patient about a pancreas cyst. My partners routinely are sending me cysts that they find just because patients have questions, as anyone would. And I'm more than happy to sit down with them and just talk about what I think their risk might be, explain the limitations, and what a reasonable approach could be. And people make different decisions. Some people are very against any procedure, even something as simple as a EGD-EUS, and others would prefer to be very aggressive and they want an EUS every year. And I think there's wiggle room and reason to do either of those. But so that'll be the end of the pancreas cyst talk. And then if you go to the next slide, we'll talk a little bit about, with my remaining time, I've got some time left, we'll talk about the dilated bile duct. So hopefully a little bit less vague in terms of what we're doing with these things, because I think people see this a lot more. But as with pancreatic cysts, as we're imaging more and more people, we're seeing more and more dilated bile ducts. And unfortunately, there just aren't that many studies really looking at what do these things do over time. There's some, they just tend to be small, and I'm going to go over a few of them. The problem is that there is a risk of cold malignancy. It is low, but it's in our pancreas, it's 2%. And that's, again, that's a low percentage, but it's not a 0%. And so it is something that I think warrants at least a thought. I certainly am not advocating that every dilated bile duct needs an extensive GI workup or an ERCP, but it is something that at least requires some degree of thought or some monitoring or further workup with some labs. Next slide. I put this up just because if any of you have sent your patients to me and they've talked about a picture I've given them, I generally give everybody this picture. I have a big stack of them. It's a nice color picture and draw right on it. It really shows the anatomy that we're talking about. And most of the pathology that we're talking about with these dilated bile ducts, if there is pathology, is in this bottom third of the bile duct, the intrapancreatic segment, because it sets you up for a whole host of different malignant processes, benign strictures, and that's also where the duct naturally narrows and tapers down to the ampulla. So obstructive things will show up there, and you'll see dilation above. So that's just our anatomy. Next slide. The other frustrating thing about this literature is what is too big. There is no clear consensus. I think that generally speaking, bigger than 7 millimeters is where we draw the line saying that it's large. But it's not something that's very rigorously studied. I was told in fellowship, 1 millimeter per decade of life, and I generally hold to that. I think a 7 millimeter duct in an asymptomatic 70-year-old, I don't worry about, but a 7 millimeter duct in an asymptomatic 30-year-old, I do think about. The gallbladder in or out thing is also a problem. The gallbladder is a reservoir for bile. The ampulla is usually closed. When you eat, it opens, your gallbladder dumps out. So when you don't have a gallbladder, some degree of dilation in the common bile duct is to be expected. But how much is hard to say. I usually just kind of add 2 to 3 millimeters in my head. But it really is the patient as a whole and thinking about all their risk factors and all their clinical parameters that decide, when is this something we need to look at. And again, this is an asymptomatic person. If a patient has any symptoms, any GI distress whatsoever, we do endoscopies, obviously with a fairly low threshold because they're very low risk, and sometimes we find ulcers, find other things. And I think the same thing with an EUS to look at the distal bile duct and the ampulla. It's, from a patient perspective, it's the same as an upper endoscopy. They're getting conscious sedation. They may have a little sore throat because the scope's a little thicker, but that's it. And I'm generally not biopsying, so the risk of bleeding and infection is very, very low. So if they have symptoms, that's different. But for the asymptomatic person, it really depends on their parameters, but I do it for the workup. Next slide. The differential is pretty wide. I tried to include, these are the most common ones. Unfortunately, not in order, I realized as I was reading this later. But choledochal lithiasis or really microlithiasis or sludge are the most common things. Chronic pancreatitis, again, because that duct does go through the pancreas right at the end. So if people get chronic pancreatitis and the pancreas starts to stricture and scar down, it can squeeze that duct. Usually your imaging is going to show chronic pancreatitis that's also showing a bile duct that's enlarged, but not always. So it's worth thinking about. And then, this is the sphincter mechanism anatomy. And that ampulla, that sphincter process, can get polyps on it, interestingly enough. Similar to the colon, they can get adenomatous polyps. They're much less frequent than in the colon, but they can develop and they can impair the sphincter's function, which can lead to a dilated bile duct or can even provoke pancreatitis. So that's an area that we look at when people get pancreatitis without a clear cause as well. Periampullary diverticulum, extremely common in our elderly population. I think so much so that those of us that do ERCP really dread doing an ERCP on anyone over 80 because there's just going to be a big diverticulum right next to or on that ampulla. It's going to be really hard to find the opening, but it can cause a dilated bile duct just because it's a distortion of the distal part of the bile duct, and so it just doesn't empty quite as easily as it would normally. And then, of course, cholangiocarcinoma, pancreatic cancer, ampullary cancer, and then papillary stenosis or sphincter of Oddi dysfunction is sort of an older term. We don't use it as much now. It used to be that everyone had sphincter of Oddi dysfunction, and then, not to bite off more than I can chew for this little talk, but there's a whole segment in the Rome criteria about sphincter of Oddi dysfunction type 3 and dyspepsia. And generally, I think we were in the past before I finished training, so I can say that it's not my fault. But we were over ERCPing people with really dysfunctional disease. But there is papillary stenosis that can happen when people that pass stones periodically and it's causing damage over decades, or people on high-dose narcotics that's causing the ampulla to be tight. And that's completely benign, but it's something you can see. Next slide. So this was a study that I could really reference for you. It's a review of a bunch of different papers. They don't do a ton of analysis, but they do reports all the studies that they can find. Next slide. You'll see that the patient population size, they're not too big. I mean, the biggest one was 500. or 400 really that had dilation, which is a pretty good number, but the rest, 100, 40, 50. Unfortunately, this is kind of what a lot of therapeutic GI literature is like. We're lucky if we get 10 people in a series and say, well, the stent worked or it didn't work. We are always sort of salivating over the cardiologist's 100,000 patients on a beta blocker or something, but we do the best we can. And these are the papers such as they are, and you can see that generally speaking for these studies, they're a little bit more female than male, age about 50 to 60, and their common bile duct size is somewhere between 8 and 12 millimeters, depending on the study. Unfortunately, a lot of them did have abdominal pain when you see presentation there, so it's not strictly the asymptomatic incidental finding, but it is a reasonable population. Next slide. And then this slide, it's very large, but as I understand it, these are all the causes that they found for the cases that they found causes. So they found a cause, and roughly speaking, about 50% of people that they evaluated, they were able to find a cause for why the bile duct was dilated. And then they broke that down. And so stones are the most common cause. CT scans really don't pick up bile duct stones very often unless they're quite large. And that's just because they don't calcify the way kidney stones do. So cholesterol stones just don't tend to show up on a CT scan, which is the most common incidental finding. So it's not entirely surprising to find a lot of stones when you look back on them retrospectively. Chronic pancreatitis, IPMN, so main duct IPMN or side branch that's impinging on the common bile duct. Pancreatic cancer, biliary tumor, unfortunately, those are really uncommon, but they were seen. A lot of these papers will say we didn't see any cancer in our 50-person series, so we don't think that's that big a risk. But then occasionally they find 1, 2, 3, 4% in some of these studies. So the cancer risk is there, but it is low. Next slide. I think that the risks for significant pathology is really my take-home point. Is if it's an older person, obviously their risk of cancer is higher because they're older. They just have had more time to develop a pre-malignant process that's evolving. Abnormal LFTs are not normal. So a dilated bile duct, I'm willing to say sometimes can be normal in the right context, but abnormal LFTs and dilated bile duct is generally speaking not normal and really should be evaluated. And that could be papillary stenosis. That could be an incidental common bile duct dilation, but they got Hep C. There's a workup that needs to be done there. Abdominal pain, certainly if it's biliary type abdominal pain, classic biliary type colic pain after eating, lasts for 1 to 2 hours, goes away, and they have a dilated bile duct, that should be evaluated as suspicious for a stone. Unexplained pancreatitis, again, for that adenoma that could be on the ampulla or early pancreatic cancer, and it's starting to block the bile ducts, so it's getting dilated, that kind of thing. Coincident PD dilation, pancreatic duct dilation, that's the double duct sign, and we worry about a pancreatic malignancy in that situation. And then intrahepatic duct dilation. It's very rare to see a benign process that's causing dilation of both the extrahepatic and intrahepatic bile ducts. Certainly an obstructing stone could do that, but I guess what I mean is a completely asymptomatic, nothing we need to do person will generally not have intrahepatic duct dilation. Once it's gotten that far, it's suggestive of something more significant. Next slide. Takeaways, really, the CBD diameter in all these studies are not correlated with specific pathology. So despite the fact that a 15 millimeter duct is bigger than a 9 millimeter duct, it doesn't seem to be associated with a worse pathology or risk for it. It's just, it is a dilated duct, so we should think about these things. We can find a cause most of the time, or maybe less than half the time. It really depends on which study you look at, but often there's a cause. And I think even if it's 30% of the time, it's better than a lot of things in medicine. And so usually some sort of workup is worth considering. The rate of malignancy, fortunately, is low. It's not zero. And so we really have to look at the patient as a whole and figure out what their specific risk is. And then any abnormalities, associated with causative lesion on EUS. For these people, like I said earlier, an endoscopy is a very straightforward procedure, and an EUS is very similar. ERCP has the risk of pancreatitis, sphincterotomy bleeds, infections. EUS, even if I'm needle biopsying something, the risks are significantly less. I quote people about 1 in 1,000 for an infection. If it's a cyst that I'm biopsying, the bleeding risk is significantly less than that. And everything else would be kind of the rare catastrophic stuff. So I think that it's a low risk procedure if it's something that we need to evaluate or analysis that we need. Next slide. So what to do about them? There's no consensus in the GI literature, essentially. If it's truly asymptomatic and a low-risk person, I think nothing needs to be done, and that's probably why we're not deluged with thousands of referrals for this sort of thing. But the long-term outcomes across populations is not well defined. The US does seem to be the highest yield just because you are getting a look at the mucosa, the ampulla, the pancreas in that area. You get a very, very good look at the distal duct looking for microlithiasis or sludge that can be there. And it's less invasive than ERCP. Some degree of monitoring or just PCP follow-up, 6, 12 months. Hey, still doing okay? Labs are okay, I think is reasonable for the low-risk person. Somebody who's high risk, we're more than happy to see them and talk about if we need to do anything else about that. And I believe that's the end of my slides. Next slide. Oh yeah, I was told to our referral information. Hopefully everybody knows how to get a hold of us. We have a nurse who's triaging our urgent referrals if you put them in. We did have an issue with scheduling. We lost a lot of MAs over the COVID crisis, but we seem to be back up to full speed now. So very happy to help with any patients or coordinate any care. Again, I just appreciate the opportunity to give this talk and be here. It's a little weird not seeing anyone, so I assume somebody watched this, and I'm happy to answer any questions.